Hi everyone, we're back with RetFix and Chill, this time live from VBS in Austin. And we have a very special guest today. We have Jay Sridhar. You may know him from the world famous and renowned Straight from the Cutter's Mouth podcast. But we were lucky. By the way, just Jay, I hope you know that your podcast was one of the inspirations for RetFix and Chill. So I thank you for that and welcome.
Well, even Windows 95 needed Windows 3.0, something not that good to precede it. And unfortunately, you see me on film. One of my senior fellows said I had, when he heard about my podcast, said a voice for film, a voice for radio. Oh no, what was it? A face for radio, and a voice for silent film, which was a great compliment. So here we are, ready to go.
The Windows 95 thing was just bars, but that was awesome. So guys, today we're going to be revisiting a topic that is very challenging for all of us. Diabetic TRDs are some of the most challenging cases that we all do, and it's amazing. Every time I do a diabetic TRD, every single eyeball is different. So I love talking to different people with different experiences and expertise to learn from their tips. So Jay, first question off the block. Really tough cases. Diabetics are really tough. I know you have a big diabetic population out in California. First question, do you do pre-op Avastin or no? Why or why not?
So the short answer is yes. I think that these cases, as you said, are really challenging. And the patients are really sick, and that's something we have to remember. These patients, we'll talk about it later, have many comorbidities. There are many barriers to getting back to surgery if something doesn't go well. I think you do everything in your power to stack the deck in your favor and the patient's favor. So, there's a lot of evidence out there. People have been like, does it help? Pre-op anti-VEGF, intra-op anti-VEGF, does it reduce post-op complications, intra-op complications? But I think most of the retina community feels, yeah, preoperative anti-VEGF is a pretty good idea. Now, why would you not do it? So some people say, well, what happens if I inject and they crunch, right? Or you get the contracture, you get a detachment. That's obviously less than ideal. I think in medicine, we're always weighing risks and benefits and probabilities, unfortunately. We like certainty as retinal surgeons. I think that you never know for sure. And certainly there are some patients who may do worse with a preoperative injection, especially if care is delayed. So it's nice to make sure that their clearance is in line and everything is lined up so you are probably going to surgery. And I also think about the timing if I'm going to do it. If I'm going to do a TRD where I'm worried about crunch, I really try to get the anti-VEGF in about 3 days max before. I don't want too long a gap. Yeah. Because if they do get canceled for any reason, I have a few more days to kind of get in that 7 to 10 day window before maybe things get more gnarly if I have to take them in 3 weeks. If I'm doing a patient for like a non-clearing VH and there's not much traction on B-scan or exam, then I feel a lot less strongly. And sometimes a resident fellow's like, oh, their anti-VEGF was 1 or 2 weeks ago. I'm like, max effect is a week, but if it's 2 weeks later, I don't feel as strongly. So it's a little case dependent, but I do like getting it in. And one of the things I also tell people is if you don't feel you have space to do it in the back part of the eye, total RD, you're like, I don't know where quadrant to go into, just do it intracameral. Yeah. And it's still worth getting it in the eye, in my experience, anecdotally, that it will still help you. And maybe, who knows, maybe it's like Dumbo's feather. Maybe it's our little crutch and we feel better during the surgery. But I don't think that's true. I do think that you have a good chance of at least reducing some of the smaller NV. Of course, larger formed NV isn't going anywhere until you go and address it yourself.
Yeah, the larger NV, like the mature vessels, they don't go away. I mean, they're mature vessels.
Yes.
But to stop those little bleeders, the Avastin's helpful. I have a ton of these patients who I don't really know whether to do the Avastin or not, and I've been burned by cancellations.
Right.
I agree if it's like a non-clearing behem, just the Avastin, you just let it ride.
Right.
The case will happen when it happens as long as the retina's attached.
And maybe best case scenario, even if it get canceled, sometimes they clear with just the Avastin, through third or fourth injection. So it's not really any harm. Maybe there's a benefit, but the cancellation issue is tricky. We have in LA just a couple weeks ago, 34-year-old, right? Bilateral TRDs. We're like, okay, let's get her set up for surgery Monday. Is she cleared? We're like, great, let's do anti-VEGF. And, Monday comes and I'm saying, where's the patient? The resident tells me, she had a STEMI. I called her this morning. She had a STEMI. And it's a 34-year-old, but these patients are a lot sicker than they look. And I think we can get tunnel vision because we're so busy and we're just seeing the disease. They have a lot going on. Everything you're seeing that's happening in the retina is happening everywhere in the body and sometimes worse. You just can't see it. It's not as tangible to the patient, not as tangible to us. So you're right. You have to really be sure you get the medical clearance. And that can be hard. I mean, you're in private practice, right? Like, how do you make sure academics or a system like ours, which is like one system, we can communicate pretty easily. How do you even make sure in those systems? Sometimes those patients don't even have a PCP, for example. Like, do you just not operate on that patient until they get a PCP? Do you have an anesthesiologist to talk to? How do you make sure they're cleared?
I mean, I have a great team of surgical coordinators. I mean, I have a lot of remote employees their sole job is to make sure they keep calling the patient and they call the primary care doctor and help them set up. I have people who help set up the appointments for the patient. Unfortunately, they still don't show up or they need cardiac clearance, so there's still limitations.
Yeah.
But I think, these patients have a million appointments, so having that support system is pretty helpful. And I highly recommend remote employees for that, especially if you can train them really well. So some people do it a week before, and I've heard very recently that some people do the Avastin in the holding area pre-op. And I don't know if that does anything. It sounds homeopathic to me, if you ask me.
Depends how long your turnover time and how long are they sitting there, right? Like I've heard anecdotally of people for like NVG and NVI injecting and holding, and then an hour or two later going, the NVI has regressed. I'm sure there's other patients that's not true. I mean, I've had NVG patients, for example, usually you inject them and the next day the NVI is gone, but I've seen a couple where the NVI is still there a day later and it takes like a few days to go away. My very gestalty kind of non-scientific approach is the longer something has been there, the longer it takes for it to go away sometimes. So that's why you have these patients with chronic NVI, for example, where it never goes away.
Yeah.
I'm sure it's better than nothing. I agree, you are, again, playing probabilities. There may be many patients where that anti-VEGF an hour or two is not going to make a difference, but it's better than nothing. Or you can make the argument that maybe you should cancel that case. I mean, this is something we're going to talk about at the conclusion, a little bit of expectations, but I do think part of the discussion is the investment on the patient side.
Yeah.
One of my attendings who's passed, Joe McGuire from fellowship, who's a great doctor and surgeon, he used to call it the come to Jesus talk. He was a priest in his spare time, additionally being a surgeon. But he would say, that is your opportunity to sit down with this patient, pull up a chair, and really talk to them about their disease. And don't allow them to feel, some of the patients just think, my retina's damaged, just like other pathologies. I'm just going to come in and get a new retina, or you're going to fix it and everything will be fine. And it's not that you want to be pessimistic, but you have to be realistic about what is actually going to happen, but also the investment on their side, right? Hey, you do need to see your PCP. Hey, you do need to take your insulin if you're on insulin. And hey, you do need to get this injection, and you do need to follow up post-operatively, not because I'm setting up arbitrary rules to make your life difficult, but because this is not a just walk into the car shop, get it fixed, and go home kind of deal.
Trivial.
It's not trivial, right? And there aren't guarantees with this. So that's sort of part of the conversation too, and also your mental planning. If you have a patient who hasn't done those things, how urgent is this surgery, right? And the timing of it, right, is very different, whether it's vitreous hemorrhage, tractional retinal detachment, and that depends on the chronicity and location, and finally a combined. And so sometimes some patients feel like, I need to get this done right now, it's going to make a big difference. And you have to remind yourself, the doctor, waiting a week to make sure you get all your ducks in a row is probably better than running in tomorrow with not everything doing and doing an in-holding injection. Because I think it also communicates unconsciously to the patient that, I can get everything sort of done in one fell queen swoop, and after that I'm going to be fine.
Yeah, these patients also, there's other questions that come up, say a patient with a bad TRD walks into your office, say there's enough of a view. Are you an advocate of prompt PRP, or
yes.
do you, if you're going to try to get them into surgery, do you just do it during surgery? Because it's controversial, right? Some people say, those hot laser burns can become holes, especially in young patients when you're peeling the highlight off. It's not like those older patients where the peripheral highlight is already elevated.
What we do as doctors is, to make our decision making more clean, we start inventing maybe arbitrary time points, right? So in my head, my arbitrary time point is, if I'm going to do your surgery within a month, I usually am not doing PR for sure. Then I'm usually not going to do PRP in that eye. And my thought is, if you think about it, the PRP is probably more inflammatory than beneficial at the very beginning.
True.
Steve Charles made the point at the conference, he was talking about retinopexy. For retinopexy, retinal burns will cause an adhesive strength, which is your goal with retinopexy, within 7 to 10 days, almost immediately.
Yeah.
But the goal of PRP is different, right? You're trying to induce ischemia, apoptosis, atrophy, and then the reduction in the VEGF level. That takes up to 3 to 4 months to get effect. Yeah. And maybe the first month, that's when their macular edema gets worse from PRP. That's when you get exudative detachments from heavy PRP. Sure. You're causing more inflammation, and if you're doing that in close proximity to a surgery, which surgery is always an inflammatory event, then I'm thinking in my head, the benefit is not there because I'm going to do it during surgery anyway. Yeah. Why not just do it at the time of surgery instead of inducing more inflammation? Now, if I'm thinking, I'm not sure if we're going to surgery. Maybe we don't, maybe we do. Or there's 2 eyes in this patient. This is the less urgent eye, and I don't know when we're going to do this. Maybe it's going to be a month or 2 or 3 months from now because it's a very chronic TRD. Then I think it's reasonable to add it in because sometimes I'm waiting. I don't think that the timing is going to really impact the final result. I know I have time to go back in later. So I'm going to probably do this eye in 6 or 8 weeks once they've got stabilized. Then I may say, let's do the PRP up front. because it does help with certain things during surgery. It helps reduce some of the vascularization. It helps define your surgical plane sometimes. There's nothing better than when you're clearing out blood and you're not sure where the retina and the hyalid is, and you start seeing scars down there because it tells you where the retina is relative to you when you don't have good depth perception. Sure. So it's kind of that time point. I don't know how you feel about PRP before.
So, I think we all remember in residency whenever a patient with bad PDR, and especially in a county setting, would come in, like a lot of retina attendants would say, you got to get PRP in because you don't know when you're going to see this patient again. Yes. So I do something similar to what you do. If I know I'm operating on them at some point soon, I don't do PRP. And I do PRP in the other eye, even if it's severe NPDR, because to me that's a ticking time bomb. But one thing that I've been doing for a lot of these patients is I don't put in the Avastin until I have a medical clearance in hand. Because a lot of times some of these patients are like, oh, I just got my foot amputated and I'm not able to make all these appointments. So there's all these factors that we are processing. It's like, all right, this is going to take a while to get into surgery. Or they tell you yeah, I just had a heart attack and that patient's going to require cardiac clearance. So that's another barrier. So I know it's going to be more delayed. I get in PRP at that point. The tough thing is, say there's vidheme. So I have a couple of patients right now, I'm hopefully operating on this coming week. They have vidheme, so I can't get in PRP.
Right.
It's been months since I've been planning their surgery for months, and ideally I want to get some anti-VEGF in, but they're already crunching even in the absence of anything. Yeah. I actually did some PRP already because I knew it was going to be delayed. So in these patients, say they get canceled this week, do I put in an Avastin, or do I just wait?
One thing in retina and in medicine we have to accept is we have control over our decisions. We do not control every outcome. And as much as I know that sounds very basic and everyone who's listening is like, okay, that's very obvious. I know we don't control outcome. But I think we sometimes get that illusion because we have so much control. And retina specialists love control. That's why a lot of us chose retina. We didn't want to be like, oh, I have to call someone else to pick up this drop lens. We wanted to be the ones in control. And yet it is a little bit of an illusion. And so what you're talking about, I tell my fellows, is you are stuck between imperfect choices. It doesn't mean that one imperfect choice could be better than another one. But the reason you don't feel good about any of your options is none of them are good. But that's not it's not your fault to remove responsibility, but that's not something you can change. Some scenarios we deal with, all the choices are bad, and sometimes you're picking the less bad one for a patient. And those are sometimes the choices that keep us up at night. At the same time, what gives us peace is probably no matter what you pick, you're probably doing the best thing you could for that patient. So if you decide to inject that patient, it could go great. It could also go horribly. If you decide not to inject that patient, it could go horribly. It could go great. So it's part of what we do is finding that balance. Diabetes is a great pathology for this, right? That's why I love diabetic retinopathy and talking about it, because it's very nuanced. And it really forces you to find that balance between being like, yes, I want to be better at these things. There are things I can do better. There are best practices. There are certain things. I don't have nihilism about this, that nothing I do matters and they're going to have a bad outcome no matter what I do. That is not true. However, it also is the balance. We have to be like, I know I did all the right things. I just have to accept that that may not result in the ideal outcome. And that's kind of a good life philosophy, honestly, for all parts of life, not just diabetic retinopathy.
Jay, I wasn't expecting you to drop bars today. Honestly, it's funny. Whenever I talk to new attendings, actually, the first 6 months are us trying to figure out, is it us? Is it my fault that this patient isn't doing well? And I think that's one of there's a mental health toll of, especially in that first year of being an attending, when you have to realize that it's a disease process, and as long as you feel like you're doing your best, that's all you can do. I know you have some cases for us. Yeah,
and again, cases we always show have amazing outcomes, right? So again, I'm a big advocate in social media context, things like that. I think we show sometimes too many good cases, right? And then that actually subconsciously contributes to people feeling worse about themselves. They see a video like this and like, oh my God, like I'm not that good a surgeon. We have plenty of cases that don't go well. And some of it is under our control, and some of it's not under control, like we said. This is the lady, this is a great example of a diabetic patient, right? 20/20 in both eyes, active PDR in both eyes. It's April 2022 at our county hospital. Patient gets lost to follow-up, so they're scheduled for PRP. They never come back. This is why your attending said do the PRP when they show up, right? Sometimes you can't. This is almost 2 years later, and bilateral TRDs, bilateral subhyaloid hemorrhage, and their count fingers on the right, count fingers on the left. And
what's your plan here?
So the hardest decision for these cases is, I think most people would see this and say, I'm probably going to operate. But we just had a session kind of about bilateral disease. What do you do when you have both eyes involved? Let's assume the patient's medically cleared. And so I actually involved the patient in that conversation. I try to find out when did each eye go bad, first of all, because you can take some clues from this. And she actually said that the right eye was the stronger eye up until a couple weeks ago. So then you're thinking, I'm not sure if the right eye is attached or not. The fovea may be attached under the blood, but maybe we should prioritize the right eye. She's telling me 6 months ago the left eye went bad. And the patient was very insistent. She's like, I want to do the left eye first. I don't want to touch the right eye because I can still see through it. She's count fingers, but that's better count fingers for her subjectively in the left eye. So you have to respect that at some point. Now, obviously, there's scenarios. Let's say the left eye was inoperable NLP. Then you're going to tell the patient, look, you need to do your right eye.
Yeah.
You need to push. In this case, I said, look, we'll schedule the left eye, and I'm going to try to do the right eye. And I try to aim for about 2 to 4 weeks staggered. And the only way to do that in the county system is to kind of save time in the schedule for her. So I'll do one eye, I'll save time in the schedule, and then I'll keep reevaluating the other eye. And let's say her left eye, when I operate, it has a delayed course, but the right eye looks pretty stable. You can keep pushing it down. I didn't do any injection or any laser because there was no view for laser in the right. And let's take the left eye to surgery with the pre-op anti-VEGF. So this is a surgical video. Dr. Blake Fortes, shout out. He's going into practice in South Florida next year. He's our senior fellow. Awesome surgeon doing this with me. And one thing that the fellows at UCLA Stein become really good at is doing these TRDs. And so I like doing the anterior posterior traction, but we're going to spend some time just looking at the section. We're pretty blessed right now, right? Like I very rarely am opening up second tools, picks, chandeliers, bimanual. We do like forceps just to see planes, but you can do a lot with a beveled cutter. We only have 25 gauge at our hospital, so we don't have the 27 instrumentation. And you can see what he's doing here is he's sort of teasing, and this can sometimes help peel things, but sometimes just helps you see where are those pegs, those very, very firm attachments between the retina. This is an experience thing. I think about this sometimes. I remember as a fellow, attendings would do things, they wouldn't explain why they went a certain place, and I'd just be like, how do they know where to go? And I've done probably more diabetic cases in the last year and a half than I did in my first 7 years out. And I've honestly told people who are like, wow, I could never do that. I'm like, honestly, I am way, way better now, and I'm not perfect than I was then, which tells you after 7 years, I still have a lot to learn. A lot of it is just figuring out with experience where the tightest adhesions are and working around it. And then I'm a big advocate of this. I teach all my fellows, it's good for them to learn to do depressed laser with a lighted laser, but go to Aura. These are really sick patients. I go arcade to Aura. To me, needing a vitrectomy for diabetic retinopathy is sort of a declarative event. You talked about earlier PRP in the other eye. It's a declarative event 2 ways, if you have NVG or a TRD or a really bad VH. Number one, it declares that this eye, I try to do all their PRP here. You do not want to have to take them back for PRP later. Yeah. The caveat is if there's posterior fluid that you're not draining where you can't laser, I'd rather not make a drain. Sometimes I'll laser everything that doesn't have fluid, and then later you can supplement the posterior stuff later if you need to, but I don't like to laser through the fluid. I think it causes a lot more necrosis. But I do go to Aura with depression because you'll be shocked how many of these patients you do a vitrectomy, everything looks great, and 6 to 12 months later they get NVG. Because what you've done is you've changed the dynamics of VEGF and the vitreous. After vitrectomy, NVG is more common because the VEGF exposure in the front of the eye increases. After cataract surgery, NVG is more common because you expose the anterior part of the eye to more VEGF. So that anterior rim of retina people leave alone sometimes, I'm a big advocate, just laser it then because it's harder too to get it later. And then the declarative event you mentioned was I am low threshold to PRP the other eye aggressively. Because unfortunately, unless there's something different about perfusion in this eye, a CRVO, ocular ischemic syndrome, if they're both PDR eyes or one eye's PDR and the other is severe PDR, the most reliable indication of what's going to happen in the second eye is what happened in the first eye.
That's a great point. It's a really nice demonstration of the segmentation techniques. I like using the combined surgery, so using the 25 gauge system and just using a peel pack for 27 gauge, and it works really well. I love what you said about PRPing to the Aura. I think a lot of people are operating without assistance. I operate without a skilled assistant. But so many companies make amazing curved lighted lasers, and we're taught to do a 360 slow depressed exam. But during that process, with a 200, even a 150, 200 interval, you can get nice laser 360, and it really doesn't add too much surgical time. Maybe 3 to 5 minutes tops.
Absolutely. And you use a repeat mode. I use continuous, but it's the same principle. It's basically you just get everything done. What I tell people the most efficient way to do it is take your dominant hand first. Do everything you can do with the light pipe in your dominant hand with the laser first. And then while you're on that side, grab the depressor and then do all the anterior side contralateral. Switch while you have the depressor in your hand. Do all the depressed on the other side with your left hand. And don't fight for posterior stuff with the depressor that you can get with your light pipe later. So these are the efficiency plays. So the reason people don't do it is they're like, man, I've already been in this 2-hour case, the view is going. This PRP is going to take forever. Obviously, you want to use context. But again, I want to quote Joe McGuire. He used to tell us, the most important thing you do during a TRD is not actually fixing the TRD, it is getting the PRP in. And in fact, he would tell some of us when we were starting, he's like, if you're really not making progress in your peeling, just switch and get all your PRP in early, if you can, if the retina's flat enough. Because worst comes to worst, you close up, you put oil in, whatever, at least you've changed the disease process a little bit. But it's worse to get in a scenario where you have significant bleeding, the cornea is going, you can't get your PRP in. Well, you could do it with anti-VEGF and ride for a bit. You have not permanently altered the disease process. It's going to keep going down the rails. And so I think it's one of those things when fellows start, they feel so bad because like it takes me so long to do depressed laser. It takes forever. I don't want to. But you can get fast at it, and you can do a full PRP. I think both hands within 10 minutes. I mean, you get really, really fast at it. One other trick is the larger your spot size, meaning the further away from the retina is, use a longer duration, use a little more power. The faster it is to do a PRP because you have fewer applications and fewer movements.
Bars. I totally agree. I think it's also one thing I will say about the Avastin is just a quick point about that because you mentioned putting in oil. I hate the bleeds in this oil and retina interface because it fibroses, and I've seen like neovascular fibrotic membranes that arise from that, especially if it sits there for a long time and the eye is still hot.
So one thing that I encountered as an attending is I think very early in my career I used a lot more oil for TRDs. I would go to conferences and people were like, I'd never use oil, here are the reasons, but I don't think I was executing in the best way. I don't think I'm perfect now, but I'm definitely better than I was before. And so a lot of times that was my crutch, is like, oh, okay, I didn't get all the traction off, I didn't do this, I have a break, I'm going to put oil in. And I've learned a lot of lessons about oil, like we all have. Number one, like you said, it induces membrane formation. If you have a big clot, that's bad news with oil, especially if it's covering the fovea. It's not going anywhere, and they're not going to have good vision afterward. Second thing is, brakes do not dictate use oil, and if you have a brake with traction, whether you use gas or oil, you're still going to get into trouble. A brake with traction at the end of the surgery, you're going to get subretinal oil. So oil is not the crutch that we think it is. Now, obviously, oil is helpful in certain circumstances. I think number one, if you got a good hyaloid dissection, but you know you have a lot of hyaloid in the periphery that for whatever reason you didn't have time from a cornea standpoint, and you can't dissect it off without creating breaks, sometimes it's good to have a little intermediate, put oil in, come back to fight another day, get your PRP in. I think that's very reasonable in certain circumstances, especially if you don't know what their potential is. So if you have a patient who's LP, sometimes I tell the fellows, you're not sure if gas is going to work, you can use oil in this circumstance. You don't have a brake that needs, you've gotten traction off all the brakes, use oil. And then you can see post-op, what's the potential here? Because that will guide your future decision making. If you've got a patient who has a great result, like this patient, we always show good results, right? This patient had a good result. Neither eye had oil in this case, but let's say you knew post-op with oil are 2100. Now you're going to be more willing to fight for other issues that come down the line. If you have a patient who's still LP and the retina's attached and everything's attached, then you're like, well, I don't know how much it's worth continuing to fight battles in this eye from the patient's health perspective and your own sort of perspective.
True.
The last point I'll make about oil is significant bleeding actually discourages me from using oil, and that goes back to the first point. So if I have a patient, I'll talk about the optic nerve. We talked about NV. Almost all these patients have a significant stock of NVD that does not regress with anti-VEGF. There's good OCTA studies that have shown you can do full PRP, anti-VEGF, whatever you want, but if you do OCTA of the nerve, there's still big vessels there that are there. They are not going anywhere. So I'm a big fan is if you don't have to pull that stock off the nerve. If you can just make sure you get all the hyaloid off and dissect off everything, leave a little stump at the nerve that's not actively bleeding, that's better than plucking it off because they will bleed off of that. Now, sometimes you have to start your dissection at the nerve or you need to get that off to get everything off. Then you take it off and you accept that you're going to get a clot at the nerve. Please don't cauterize the nerve. Mackamer, about 40 years ago, he published a paper where he cauterized the nerve, and he said, you know what, that's not a great idea. All these patients are NLP after. And thanks to Mackamer for publishing that, so we didn't have to do it ourselves. I think that, though, if you do have that clot in the nerve at the end, that also encourages me more to use gas, because I know with gas you have higher surface tension, you have a higher chance of it being displaced, and a lower chance of it being permanently trapped, because even if it doesn't displace it, as the meniscus passes the nerve, then it will shake out into the aqueous component of the vitreous. And you might lose your view for a little bit, but at least it's not trapped there to form a new membrane. I think with oil, you're pretty much guaranteeing it's going to be trapped there until you go back in and take the oil out.
Yeah, I love what you said about the surface tension too, because I think if you have a lot of bleeders at the end of the case, the gas buys you time.
Yeah.
Right, and it fractionates into the heme fractionates into the fluid phase. But I think this is a great result. I mean,
look, so we did the left eye first. Actually, we did the left eye first and the right eye later. She's not that happy with her left eye vision, and I didn't bring the OCTs, but she had a big fold, if you notice, supratemporally.
Yeah.
She still kind of has that fold, and it's funny, I have residents come to me who think that retina surgeons can fix everything, and they're like, oh, how are you going to get rid of this thing? And I'm like, there's not much you can really do. Her retina's kind of bunched there. We peeled everything off. She has ILM off that area. She's got an intrinsic fold that slowly is relaxing, and I've told her it's a year out now. I saw her about 2 weeks ago, and I said, that may continue to get better. But right as 20/50, which is a home run result, right? Life-changing for a patient like this. But the biggest thing is she hasn't had any post-operative issues. She hasn't rebled. She hasn't gotten NVG. Now, part of that has to be accepted as luck, but stack the deck in your favor. Do your full laser. Make sure you don't leave any active fronds. And then I think the biggest complication of diabetic surgery is not redetachment, it's actually repeat bleed.
Yeah.
So I think about all the things at the end of the surgery that could cause a repeat bleed. Obviously, active bleeders, you want to try to address them in one form or another. If it involves leaving a small thing to clot, great. If you need to cauterize it, do that. If you need to laser it, do that, but address them. Second is avoid postoperative or end of surgery hypotony, right? So very low threshold, suture your wounds. Sometimes, even if it doesn't dictate that I use gas, sometimes just to keep the pressure up, I'll use like 24% SF6 at the end of a case with no breaks, just to make sure the pressure is higher. If I think the patient during surgery was pretty oozy, I don't want the pressure to dip below 20 or 25. I'll leave them with a little gas, and I'll say, you know what, it's great if they're 30 on day one, because at least I'm preventing those bleeders from coming back. And the last point, Pradeep Prasad, who's an attending at UCLA, taught me this indirectly. I actually learned it from Mike Kloufis, who was one of his former fellows, and now Pradeep and I work together. But Pradeep talked about, he always drops the pressure to end the case to 10 or 15, just to look and see, is there anything that will bleed subclinically if I'm at a normal physiologic pressure? Because that's the biggest disappointing thing, is you do this great surgery, and then the next day there's still hand motion and they've got blood everywhere. And now you're sitting, and you don't have a view, and you're sitting on it. And even worse, if you were planning for surgery for the other eye, and now you're like, well, now what do I do? Because this is the functional eye, but now it's non-functional. Do I take this eye? Do I wait? It messes up some of your really well-constructed plans that you had before.
Yeah. Or do you do an in-office push-pull technique?
Have you done that before?
No, I haven't.
Okay, I haven't done it either, so I feel better.
I haven't. I like the idea of it, but honestly, especially in a pseudophakic patient, I'll do a push-pull technique all day.
Yes.
But a lot of these patients are younger, and they're phakic.
So
and I just don't want to stick a needle in.
So that's the follow-up question. What's your threshold to take the lens or recommend like, what do you do about the cataract? How bad does the cataract have to be where you're like, get this cataract out? What do you think about?
Even 3 to 4 plus NS, I think we can all operate through, but it's when the 3 to 4 plus PSC, especially if you've used gas. I know people say that a lot of these patients don't get cataract, especially with gas.
Yeah.
But it's interesting actually, because I feel like a lot of times I get cataract is when that anterior hyaloid that's right behind the lens that gets smashed up against the lens at the end of the case.
Yes,
with
by the gas, yeah.
And I think a lot of the posterior changes are resulting from that. I've never heard anyone talk about that, but I'm just like, I feel like if I had taken this more, they wouldn't have gotten this posterior.
Hard to take it without damaging the lens.
Exactly.
Though. So I think there's 3 things I think about the cataract, right? From a why would you do it? And we do a lot of combo if we can. I'll talk about when I do combo versus referring. Some people don't have the option of combo, but for us, operative slots is like our number 1 limiting factor. So it's better to make the case a little longer sometimes and save a slot for another patient if you can get the cataract done and it doesn't hurt this patient. So number 1, you take the cataract if there's significant anterior blood plastered against the capsule before you start. Because it's going to hurt your visualization during the surgery because you're not going to get all the blood, and they're not going to be able to see well after the surgery. So then think about combo surgery. Second is obviously if the cataract's so bad that you don't think you'll be able to operate through. Now, like you said, you would be surprised sometimes. You can operate through lots of things. And the third reason I think about taking the cataract is, again, functionality. So if I have a patient who needs to be functional and they've already got a 2 to 3 plus PSC, then I'm like, it's great I fixed their retina, but they're still not functional. They can't take care of their diabetes. So maybe it's not a bad idea to do both at the same time. Now, the cons to the same time, right? Or staged. So you need to make sure that they make it from staged cataract to vitrectomy. So sometimes they have staged cataract and they disappear, and that is bad news because it's inflammatory, you didn't address the posterior problem, and things only get worse, not better. The second part is during the surgery, if you combo it, I think in my head, if I can do this case in under 90 minutes, the retina portion, then I will do the cataract at the same time. Meaning if I think it's a VH, not much traction, TRD, but it's not too bad, then I'll say, great, let's do the cataract at the same time, because I'm thinking about that cornea clock. I'm thinking, when is that cornea going to start to opacify? Because I hate scraping corneas.
It's the worst.
Yeah, because they don't heal well.
Especially in diabetics.
They're neurotrophic, you laser the cillaries a lot of times, they don't heal well, so I think 90 minutes, more or less. If it's like a really bad TRD back there, or I'm just trying to get a sense of like what's their visual potential, sometimes I'll say get it staged, and then we'll reassess afterward and do the TRD. But the cons of doing it at the same time, it's more inflammatory, right? So you're going to get more exudation, more inflammation, more higher risk of a fibrinoid response, for example. You can get more synechiae. So be prepared to bomb them with topical steroids and SDK. Just think about these things because diabetics get an abnormal inflammatory response too throughout their body. They don't heal as well. Just from, again, a gestalty, anecdotal sort of point, I tell the patient, you're not going to heal quite as well as someone else. So you're just adding in another variable. So I still do a decent number of combos, but I'm okay with staging if I can make sure I have both dates sort of secured before.
Great points. I mean, I think a pro tip actually for if you ever have to scrape the cornea. By the way, I've had to barely scrape the cornea since I switched from some of the other brands to Viscoat.
Way better.
Viscoat is outstanding.
Better than OcuCoat. And I don't need financial disclosures, but one of my fellows pointed that out recently, actually, because I was always like their equivalent. And my fellow, again, I'll give Blake Fortes a lot of credit because he's taught the other junior fellows this. And now we use Viscoat as much as we can. For any case that we think where it's going to be a problem, we break out the Viscoat. Even during the case, if the cornea is not great and you put Viscoat on top, it improves, which is fantastic.
Yeah, it's
fantastic. And it's
fantastic.
better than OcuCoat, even though technically when you look at the two labels, they look very similar. So someone smarter than us could comment on this in the YouTube channel. I don't know.
Exactly.
Yeah.
If you do have to scrape, what I really like to do, not a bandage contact lens, but they have these 24-hour collagen shields. I love those, but they don't have it available anywhere. One quick comment. I personally have no problem doing combo surgery. Like I would do the phaco myself, especially, and like I have like great referring doctors who can get in cataract surgery very quickly, but I tell them like, hey, I might need to do this during the retina surgery. But why am I not able to do it? Because I can only do that in a hospital setting. A lot of ASCs don't get paid for both codes, and this is a 67113 complex RD repair. So like any lensectomy procedure that you do,
it's bundled.
Is bundled.
Yeah.
So this is like like a big advocacy issue because these patients are needing more surgery.
For sure. And we got to think about that when we go and advocate. And I think for the individual doctors out there or fellows, it all depends on where you're going to practice. You got to figure out wherever you practice, what is the bottleneck? What is your rate limiting step? And that was the first thing. I was a job, I was academics for 7 years. I would do combos sometimes, but I didn't do it all the time. But actually sometimes I would combo because I was thinking in my head, a lot of these patients have deductibles. They have a copay for each time they go to the OR. They can't afford it. So I'm like, I'd rather try to do it if I can. If it's safe for them and it's not a bad thing, do it all at once.
Yeah.
Now I'm in a situation where I'm like, they don't have that. So if I split it up, it's actually not the end of the world. So I've actually adjusted a little back from that. But I do think about they got to get cleared. They got to go to the OR, and we only get this many retina slots a week. So it's a balance, but you always have to think about what is the situation you're in, where are you operating, what is going to balancing the needs of the patient, advocating for them, for what is realistic in terms of the pathology that you have to work with.
Yeah, I mean, I think that's well said. I mean, every patient, every eyeball is different, and I think you have another case for us that further demonstrates that.
So this is interesting, right? So this is an autistic young man. He's nonverbal. He's monocular. His sister comes with him. They're super, super nice. He's actually pretty reasonably compliant. You can take photos of him. You can examine him. He couldn't do a pre-op injection, right? So you have to think about this situation where you just can't do it. He won't sit for it. It's not worth it to me to put him under anesthesia just to do a pre-op injection. True. I was like, and she kind of told me right up. She does make his decision for him. He's like, honestly, I just wanted to have one surgery, one and done. And so we talked about it, and he's NLP in one side. The other eye here, let's go back. The other eye here is like 2,400 count fingers detached. So he said, look, the NLP eye, there's not much we can do. He's pseudophakic in this eye. And I was like, look, are you okay if we just use oil? She's like, I don't want him to ever go back to surgery. I'm like, well, oil doesn't guarantee it, but it has a better chance of him never needing another surgery if we plan to just leave it. So we planned on oil from the beginning. And that instructs a lot of our decision making, right? So we clean the PCO. I usually work through it if I can, but here we also knew we wanted to open the capsule so he doesn't get an opacification that requires you to go back and clean and exchange the oil. And a lot of membranes here. So from the beginning, I was working again with Dr. Fortes, and we kind of said to each other, we're like, look, we just need to segment enough to get traction off so he can be reattached centrally. Let's try to avoid a break here. Let's try to avoid anything that can cause issues down the line, understanding the needs of this patient, what his sister prefers, which is very reasonable, and also he's going to have oil long term. We don't have to be quite as crazy about getting everything off. So we're still going to dissect. We're still going to get things down. We're going to do a full PRP. We're going to leave a little more than I would normally. And I don't know how you think about it. Do you balance how much you take depending on the patient situation? Like, do you think about this at all?
Honestly, it depends on how tightly adherent obviously social
risk benefit of what pulling versus not pulling. Right?
Exactly. I mean, because especially you can see on the OCT sometimes, but like if something is very tightly adherent, I have a low threshold.
You could see there's that the phobia is attached to that thing. So we were just like, hey, that has to come off.
Yeah.
But everything else, we're like, okay, we're here. We're already lasering. We're just saying, okay, that's good enough.
I leave a lot of. But the most important thing is I think staining with. Steroid, I think that really,
which we haven't
really
talked
helps.
about. Yes.
And I think that's super helpful. First off, that's inflammatory because there's always some steroid that's left at the end of the case. So I think that's, no matter how much you wash out, you still see a few little particles. But I think what's really helpful is it helps you see all the adhesions. Because it may look like, oh, I've trimmed that down. But with the steroid, you see it's like, oh, there's a sheet of hyaloid going anteriorly, and that can still contract and bleed and detach. So
the other things about steroids, first of all, I try not to use it right at the beginning if there's a lot of tractional membranes, because I always tell my fellows, if you can see stuff to do, don't put the steroid in, right? You got work to do your work. If you ever reach a point where you're like, I'm not making progress, or, hey, I think I did everything, I feel like I did a good job, then restain and have the humility and the expectation that you're going to find more stuff and break those adhesions. And look for clues that the hyaloid may still have another layer, that vitreoschisis with another layer down. There's two big clues. One is that sheen that sometimes you've seen. So you think you did a great job, but you're like, why do I have that sheen temporal to the macula? It's like, there's probably a layer of hyaloid down. You just
Yeah.
need to find an edge to lift it up and stain it. And the second is if you see blood that's trapped on the retinal surface, that's pre-retinal, that is not moving,
Yeah,
that's also a bad sign. That means it's not a bad sign, but it means that you still have something down. And so if you look inferiorly and you've got this trapped little clot outside the arcade and it will not go anywhere, there's probably a sheet somewhere. You just need to figure out how to get into that space. And it's fascinating because you do your AP traction at the beginning. You're like, I got this whole layer off.
Yeah.
And then we did a case recently with one of my other fellows. There were 3 layers of hyaloid down. You took out one, stain, and every time he was just like, he felt, and then of course most good fellows are like, oh, what's wrong with me? I didn't see that. And I was like, this is experience, right?
Yeah.
Like you just have to keep lowering your expectations to be like, there is probably going to be another sheet, and I need to look for it really carefully and diligently, and that will again reduce the chance of another complication down the line.
It's so interesting because, I think that sheen is one thing, but like one thing, I had a case recently, super interesting, phakic, bad TRD with a full thickness macular hole from the traction. So, I did I peeled Brilliant Blue, ILM peel, and the question is how aggressive he's phakic, he's like 40, how aggressive should I be with the peripheral hyaloid? So, I did a 360 shave and I did a good PRP.
Prior PRP already?
Prior PRP already as well.
And that tends to make, weirdly, the hyaloid sometimes is more stuck.
It does.
Yes.
It does.
Which is why someone like Maria
Young
Bierkal
patients.
says, hey, don't do the PRP because it makes the hyaloid stickier, which is that pro-con, right?
Exactly. And actually, what's weird is I remember, because I have a video of this case, and I was like, you know what, I'm going to leave a lot of this peripheral skirt of hyaloid because if I chase it and if I try to peel it, I'm going to end up with, creating breaks. So I went to air, and in air, I saw in the video later that, there was this little curve, like basically mid-periphery equator, like this little reflection. I'm like, okay, that's fine. I get my laser in. 5 months later, the patient detaches with multiple breaks exactly along that area. So when I went in for surgery, I saw that residual skirt of hyaloid was all still connected circumferentially, so it contracted and caused multiple breaks. He's attached under oil now, with poor visual potential. He's like 2200. But the question is, how aggressive are you on these?
What I love is you did what a lot of people don't have time or don't take the time to. You went back and watched the video later to try to figure it out, which is like the number one most important thing to being an awesome surgeon like Dr. Zahid is like, no, but seriously, like self-improvement. Like, hey, what could I have done better? Something didn't go well. Was it something? It's exactly what we were talking about at the beginning. Like, could I have done something differently?
Is it me?
Is it me? And sometimes it is us. Sometimes it isn't. You can't fix everything. And I think the thing we didn't talk about is like, how do you know how much to do, right? That's kind of what you're alluding to. Experience helps, but context is everything, right? Is your patient bucking on the table and all over the place?
Yeah.
And you got to start changing your goals. Is your patient looking ischemic? What's their blood pressure at? Is their nerve pale or pulsating? Like, you got to think about other things so you don't end up with surprises. And this was a quote passed on from Tony Capone to Rich Kaiser. Rick Kaiser's one of my attendings in fellowship. Tony Capone once told Rick Kaiser, who tell us this thing, he's like, if you're not making progress, you have to move on to the next step. And so the balance of being a retinal surgeon is not we don't like to give up on things. I'm not saying give up. We like to be doggedly persistent. But don't go on tilt and just not bang your head against a wall if you're not making progress. And that goes even for membranes. If you're working on one area and you're just not making any headway, go work on something else for a little bit. Because in a weird way, it will relax you because we get more and more uptight and you get more sweaty and you get more tense because you're feeling things are going well. If you're working on a nasal thing and you're like, I'm not making progress, go work on that temporal thing for like 5 or 10 minutes.
Yep.
And then come back. And sometimes you come back or you approach it a different way and you're like, oh man, if I had switched hands like 10 minutes ago, I would have gotten it, right? So just try to think about, I'll approach it this way, I'll approach it that way. Be flexible. Don't be dogmatic that it has to be exactly this way. And it'll make you a lot easier to have shorter cases. So these cases, that's the final thing. Some cases take forever. I'm not criticizing people who have 4-hour TRDs. But ideally, we don't have those cases. There are ways to make these cases faster and faster over time, to be efficient, to be goal-oriented, to say, okay, this, then this, then this, because that will also be better for the patient, because the shorter the operative time, generally, if you achieve goals, the better it's going to be. Absolutely.
Great points, great advice. So this patient had a nice outcome. I think that's really great.
So I've seen him recently. He's out to a year now. He's 2050 or 2060 with refraction.
Fantastic.
Very happy. I've actually brought up the oil issue, and in fact, his pressure. We put oil in. We filled him fine. His pressure's crept up a little bit over time. So I had the conversation with him, like, hey, what's easier for you guys as a family, eye drops or surgery? And she's like, no, I don't want him to have any surgery. He's doing great. He'll put in the drops with me. I'll take care of it. And so he's using like COSOP twice a day. Keeps his pressure in the low teens. It's his only eye, and honestly, risk-benefit, I'm just like, it's fine if you want to keep your pressure on the lower side rather than hovering on 20, 21 all the time.
For sure.
And he's happy. And you know what? Things change. He's got a long life. He's 39 or 40, right? Is he going to have his oil in 15 years, 20 years? I don't know. But
when it starts emulsifying, it might cause a different
And that's
issue.
what I've told them. I've said, look, if at some point the risk-benefit exceeds, and they're like, we trust you, whatever you think, if you think at some point it makes sense to do it, then we do it. And that's kind of the decision you have to make for someone like this.
For sure. So you've shown some awesome cases. These patients did well, but as you mentioned earlier, sometimes, whether it's because of the disease in that eye itself or because of other factors, other illnesses, these comorbidities these patients may have, sometimes these patients don't do well. How do you counsel these patients?
So we're really blessed that the majority of our county patients are very understanding and empathetic and actually get it. But you do have some patients sometimes who have expectations that don't line up with their disease state. And I'll get your advice on this. I think you got to have a tough conversation at some point. And it's just a question of when do you have that? How do you break bad news, right? Do you break it in pieces? Most studies show it helps to do it sequentially. Do you do it all at once? Depends what happened. I just think that you have to tell patients that there are no guarantees when you go to diabetic surgery. There always is the chance that they could be worse afterwards, low, but that's true for any eye surgery, but especially for these patients. If you really want to get prognosis, I don't do this that often because usually you have other clues, or usually the view is not good enough to get an FA or an OCTA. But you can get an OCTA or an FA and people like that preoperatively to show the patient, show yourself, hey, they have macular ischemia. Like that's going to limit the visual outcome. I just think, but I try to have that conversation early on. Without being, it's that balance, right? Like you have patients, I'm sure, who come for second opinions from other retina doctors, and you don't know what happened in that conversation. I'm sure the doctor was really empathetic. The patient's very upset. They said, that doctor told me I'm never going to see and I'm going to be blind. And you're like, I'm sure they probably didn't say it that way. Mm-hmm. But I think sometimes we struggle to give bad news because we also don't like it subconsciously. We don't, no one of us went into retina to go tell someone you're blind and I can't fix you. So I think sometimes we either cut those conversations short or abrupt or uncomfortable with the emotions of it. And maybe that's why some patients get really upset. So I think taking a minute to sit down, be at someone's eye level, understanding they need to process it. They're not going to process it all at once. They may have expectations that don't align. And involve family members when they're helpful.
Always.
Sometimes they're not helpful, but most family members are pretty helpful. And most of them have enough perspectives that the patient will go home and their family could be an advocate to explain, hey, I know the doctor says there's no guarantees, but he did say, or she did say, that you should do this, you should do this. And a lot of times that's the person you have to rely on that's going to help push it across the finish line. Because a lot of these patients, they ended up with really bad PDR. Mm-hmm. There's a lot of socioeconomic reasons, a lot of social reasons. There's a non-adherence issue, right? I don't like the word non-compliance because you have patients who have a lot of problems. I have a patient recently who he's a methamphetamine addict, right? And he's coming off treatment. His mom is really trying to help him get care in his only eye. You have to open yourself up to help someone like that because he's got a window and a chance to save his life. But it's not going to be easy, and it's not going to be straightforward, and you've got to be a little bit patient working with someone like that. They're not going to get it all at once.
I think it's a great point. I mean, I think I also try to have these conversations very early on. I've become pretty good at having it in like multiple languages. It's hard, it's hard.
English, Spanish,
Bangla,
yeah.
Yeah, the hard part, honestly, is conveying to the patient that the fact that there are no guarantees, but we also want to give them hope. You want to be like, look, there are no guarantees. First off, like I tell these patients, we're going to be best friends. Our goal is to maintain or maybe get better. No guarantees that it's going to get better, but we're going to be best friends because you're going to see me more often than you see a lot of your family members. Because it's not just a surgery and you're out. These patients have DME. They're going to need, they may need additional surgery. They're going to need injections. So establishing that relationship, I think, is really helpful. And I've had better luck when you have. I think we all have better luck when we get buy-in from the patients.
When you have rapport.
Yeah.
Yeah, and I think patients, informed consent's an interesting thing, right? We joked about this offline, but informed consent is informed consent, but it depends on how you phrase things, right? And so I think what I've found most patients they prefer to hear about options, but they also want to hear which option you recommend and why. Right?
For sure.
And that's where some people run into trouble when they start, is they're like, I presented the patient the options, and the patient will then be like, well, the doctor didn't have confidence because they didn't tell me which one to do,
right.
Which is an interesting thing because you're trying to be patient forward, but patients ultimately do want you to put your foot down in one way and say, well, this is what I would do in your situation. Or if you were my family member, this is what I would recommend. Right. So I tell most patients, I talk about blood sugar, blood pressure control. Obviously, blood pressure control is big post-operatively. And then I say, look, you can do laser, you can do injections, you can do surgery, and I kind of go through their options for that individual eye or each eye. Sometimes I say, look, this eye is easy, this is what I would do. This eye is the harder eye, to give them context that, hey, we got a bigger problem on this side. And walk them through, and then say at the end, look, this is what I would recommend. And then, you've got to meet them halfway. You can't force people to do things they don't want to do. That's the other part. Some people don't want a preoperative injection. And I would say 99% of people, when I explain to them that, hey, it will help your surgical outcome, they'll agree to it, even if they're scared of injection or tired of it, they'll do it. But I have a guy I'm operating on Monday. He was like, I cannot do it. I am phobic. I'm going to go crazy. And I was like, look, it increases your chance of bleeding, increases problems. Are you okay with that? And I understand his pathology is not so bad that I may regret this in a couple days, but it probably will be okay. We did surgery before anti-VEGF. But if I had tried to force him, he would have run away, I think, right?
Sure.
And that's the and he would not have come back. Or he comes back a year later with a TRD and NVG, right? So like you got to sort of feel people out and figure out like where are they coming from, what are their needs, what are their fears, and a lot of it is like you referenced language barriers, cultural barriers. What are they afraid of? I don't know if you've seen that. I've had patients who are afraid of getting injections, laser, or surgery because they know someone who had a bad outcome.
Yep.
Right? And so like then you have to meet them halfway because again, if you try to force them to do something they're terrified of, it's not going to end well. And so you've got to balance how important is that thing, being dogmatic, that is the thing I have to do, versus, okay, it may not be the perfect option, but I'm going to pick the option that they're okay with because that's something.
Exactly. And it's all about working with the patient and figuring out, that specific eye. Every eyeball is different. Like I think, we all learn. And these are really tough cases. And I think, thank you for sharing a lot of these amazing
No, it was great.
tips.
This is fun.
I think the best part about all this is we're all constantly learning and getting better. And I love doing these podcasts and talking to like people who have a different experience than me, because we all learn from each other. And I think that's a really beautiful thing, especially with the complex disease.
We also have we're opposite coast, 3,000 miles away. We never trained at the same institution, didn't overlap at all, and yet there's that convergent evolution, right?
I love it.
Where there's so many similarities in the problems we encounter, and that's why these conversations are so important to all of us.
Yeah, and fun.
Yeah.
Thank you, Jay.
No, thanks, Star.
Another great episode of RetFix and Chill. We're signing out here from Austin. Catch you next time.